It's really an honor to be here. This is a topic that means a lot to me for multiple reasons. I'm a hepatobiliary surgeon, so in New York, in the US, my primary focus is actually on liver cancer, is on liver surgery, and the #1 diagnosis I treat is metastatic colorectal cancer. So about 60–70% of my practice is liver resections, and the majority of that is for resecting colorectal liver metastases. It's a disease that's always fascinated me because although I operate only on patients with stage 4 disease, we cure 20% of patients with stage 4 disease, which is very rare for most metastatic cancers. And taking it to another level, in colorectal cancer of the young is also very personal to me because I see a lot of patients. We're a referral center. If you're a young patient and you have this problem, you get on the internet, you look, and you're willing to travel from anywhere around the country. So just 10 days ago, I operated on a 35-year-old who had 2 colorectal liver metastases. Every month, myself and my partners are operating on a lot of patients in their 20s, 30s, and 40s with metastatic colorectal cancer. So this is a topic that I deal with a lot in my day job, and in my nighttime, weekend, and sometimes weeks at a time job, I'm also the director of our Global Cancer Disparity Initiative. So I'm going to try and describe a little bit about cancer in low and middle income countries, tell you a bit about the organization we've created, and talk to you about young patients with colorectal cancer in a place like Nigeria. People generally think of the largest public health problem in low and middle income countries as being infectious diseases. It's starting to change a bit, and now there's a lot more talk about non-communicable diseases, or NCDs. Cancer, diabetes, heart disease. And the rates of those are really rising. And a lot of this has to do with lifestyle changes. Life expectancies are higher. Infectious disease treatments have improved. And so we and others are involved in cancer specifically and are working a lot on guidelines, training, and in our case, surgery. So this is a slide that shows you the ratio of the incidence of cancer to the mortality rate. And you can see over here in the high-income countries, over here, that ratio is very low, but in low-income countries, with every single cancer, it's very high. And there's a multitude of reasons for this, which I'll get into. This is one of the first looks that I did at any data related to cancer. I'd spent about 2 months in Malawi when I was a surgical resident in about 2008, and I had gone through all the surgical books to see who are they operating on, who even makes it to the hospital, who gets an operation for cancer. And so this is just a snapshot. This is over about a year's period, and you can see there's an odd breakdown for us when we look at this, because esophageal cancer is very common. There's a belt in Africa of a few countries where esophageal cancer is the #1 or 2 cancers. But you can look at the mean ages here of the patients that were having surgery, and all of these ages, other than prostate, are incredibly low. Breast cancer, 39 years. Colorectal cancer, 47 years. And this is a theme. This is not specific to colon cancer. This is specific to all cancers outside of prostate cancer in low and middle income countries. So these are 2 patients that I've been involved in treating in Nigeria. This is a woman with breast cancer. This is a small breast cancer in Nigeria. The majority of women present at very young ages with a risk pattern that goes against what we say. So these are young women who have 5, 6, 7 children who've been breastfeeding for 15 years. And are presenting with large palpable masses, oftentimes the whole breast replaced by cancer. Our modality for treating this here is totally irrelevant. Mastectomy is the only way to treat these patients. They have no access to radiation. You have access to any type of chemotherapy you want as long as you have money, because it's a self-pay system. This is actually a rectal cancer. Every once in a while in the US, we may see a very advanced anal cancer like this, but incredibly rare to visibly see a rectal cancer in the US. This is a low rectal cancer that had grown out the rectum. And this is also not uncommon there. I've also seen patients where it's grown through the abdominal wall. So there's a visible tumor on examining the patient's abdomen. This is a 26-year-old who I operated on with my colleague in all of this, Isaac Alatishe, a Nigerian surgeon. And we operated in, this was 2009 or so, in the middle of the night. 26-year-old came in with large bowel obstruction from advanced rectal cancer. And in the middle of the night, we were operating on him to give him a diverting colostomy, just to palliate his symptoms. And in the middle of the case, we found all these white specks around the abdomen. And I asked Isaac what they were, and he said, you're a cancer surgeon at Sloan Kettering and you don't know what peritoneal metastases are. I don't understand this. And I said, no, but this doesn't look like the peritoneal metastases that we see. These were these very soft, flimsy things that you could just wipe off with your hand. Ours, when I biopsied, I have to cut it out. So they physically looked and felt different. And Isaac said, well, this is what we see. We see a lot of patients in their 20s and their 30s who come in with obstructing rectal tumors. This is an average occurrence for us. So this is sort of our index patient where we said, well, let's look retrospectively even with whatever we can with your records and see how are patients presenting and what happens with them in Nigeria and compare them to my hospital. And the general characteristics are early age of onset, aggressive disease pattern, bulky tumors, and late presentation. And because of all this, we thought it was worth investigating what we were seeing. Now, at the same time, there have been a couple publications out of Nigeria that have been talking about the increasing incidence of colorectal cancer. And this is not of the young, this is just in general. And colorectal cancer is not a cancer that comes to most people's minds when they talk about cancer in Africa. But if you talk to a surgeon, a general surgeon in sub-Saharan Africa, they'll tell you that a third to a half of their ward is filled with patients with colorectal cancer. And when you look at the data out of organizations like GloboCan, which gives epidemiologic data about cancer in Africa, it's generally the third, fourth, or fifth cancer. Breast cancer, cervical cancer, prostate cancer being generally the most common. But the rates are clearly rising, and the data is basically non-existent. Even an organization like GloboCan is using 3 or 4 cancer registries in the continent to give data, extrapolate data for each country. So the data is really non-existent. So we started by doing this retrospective look. We got 160 of Isaac's patient charts, and we pulled records that we had at Sloan of just stage 3 and 4 patients, because there's really no stage 1 or stage 2 patients in Nigeria. And we looked at things like how were patients presenting. So it was very common in Nigeria to present with obstruction. We looked at the sites of presentation, and we've seen today, and especially in our first talk, which is based on hundreds of thousands of patients worth of data, the different breakdowns of sites of tumors and stages. And you can see in Nigeria, it clearly appears to be different. There was a predominance of rectal cancers, and almost every single patient had a T4 tumor. So all those tumors are staged with T1 through 4, T1 meaning smallest, T4 means it has broken through the colon and invading other structures around it. And that's almost the rule in Nigeria. And not surprising because of that, the majority of patients presented with stage 4 disease or advanced stage 3 disease. It was basically unheard of to have stage 1 or stage 2 disease. So then we compared the survival between their stage 3 and our stage 3 and stage 4 patients. And as you would expect, there's a huge difference here between all of these survival curves. And there's a lot that can go into this. I mean, this goes down to some of the basics like access to healthcare, finances, comorbidities. The list is long as to how to explain the difference here. But because of these differences and because of how common it is for these surgeons to treat patients with colorectal cancer, we decided to create a prospective study group. So we created this multi-center group. OAU-THC, Obafemi Awolowo University in Ile-Ife is one of the well-known universities there. And that's where Isaac is based, so that's really our home center. And from there, we've branched out and now built a collaborative group with 5 other hospitals, or 4 other hospitals. So a total of 5 in Nigeria and ours at MSK. And each hospital team is comprised of a surgeon, a pathologist, and a radiologist. You'll notice that medical oncologists aren't included in this, not because we have a problem with them, but because they don't exist. In most low-income countries, especially, the field of medical oncology is taken over for solid tumors only by surgeons. So the surgeon for breast cancer, for colon cancer, is the person who diagnoses you, does your surgery, and writes for your chemotherapy. And so we've combined these 3 fields. And we started this in October 2013. I don't have a lot of statistics. The last 2 talks were much more impressive in the breadth of statistics and numbers. This is completely lacking for all of sub-Saharan Africa. I crunched a lot of these numbers in the last 24 hours, so no real statistics. I'm going to show some trends here, which I think will be pretty obvious what the differences are. So the median age in Nigeria, and this is of our 180 patient cohort that we've now prospectively collected data on and collected tissue on. which is a very unique data set. It's the first of its kind in sub-Saharan Africa to have a very robust prospective data set. So the median age was 53 in Nigeria for presentation, US 68. The percentage of patients younger than 50 who present with colorectal cancer, 41% in Nigeria. And as we've seen, the numbers in the US can range anywhere from 5 to 10 to 15. And here I just split this out so visually you can see that this, when we talk about colorectal cancer in a place like Nigeria, it's not colorectal cancer of the young as a separate disease. You're really talking about colorectal cancer. And so I just tried to show the trends next to each other. This is all SEER data from the US. And the age groups don't line up well, but if you put 50 here and 50 here, you can see that there is clearly a huge shift to the left in Nigeria in how young these patients are in their presentation. Rectal cancer is the most common, 57% of patients. And then the next step down was right colon cancer. And this goes against a lot of what has traditionally been published from Africa, where it was thought that rectal cancer was even higher than 60% and that right colon cancer was very rare. In doing this prospective data collection, we're disproving a lot of longstanding beliefs. The belief that patients in Africa don't have polyps, we're finding them in 20% of patients. That patients in Africa don't have diverticulosis, we're finding them in 20% of patients. So as we're collecting these data, we're disproving a lot of what has traditionally been thought. When we looked at our first 145 patients and we looked at the stages, it was 64% presented as stage 4, 0% as stage 1. Here, the SEER data, stage 2 and 3 is considered regional. So this 36% is for stage 2 and stage 3. And these are actually, these numbers are basically the same. But the flip-flop is really that there's no stage 1 patient in Nigeria, and there's 40% in the US because of our screening. And in Nigeria, it's the exact opposite. And we've also looked at the metastatic pattern, and there's some differences here that we're just starting to try and begin to understand and ask questions about. The majority of patients present with stage 4 disease. It's unknown what their metastatic pattern is in the past. We published on it retrospectively, but none of those patients had CAT scans. So it's patients come in with symptoms, they get a laparotomy in the operating room to fix their symptoms, to get a colostomy, and then the surgeon looks around and says, well, I saw peritoneal metastases, I didn't see liver metastases, and that's the level of staging. So in our prospective study, we got a grant from the NIH to help pay for CAT scans, to actually stage patients and determine what actually is happening with these cancers. And there is a very high percentage of patients with peritoneal disease, 63%, and a high percentage with liver metastases. And at Sloan, when we had about a 2-year period where we looked, of the stage 4 patients, half had liver, and there's some selection that goes into this. We're a major liver surgery center, so patients with this are referred into us. But a very low percentage had peritoneal disease. And probably a lot of this has to do with the fact that I think, although we stage T1 to T4, in Nigeria, they sort of laugh and say, we have a T5, because the tumors are massive. And we had an X-ray conference 24 hours ago where we're looking at tumors that are filling the colon and a quarter of the abdomen, because patients are waiting until they have very, very late symptoms before they come in. So it may be that we're just watching the natural history of what happens with a T4 tumor when it's left to grow for a very long time. When we look at the mortality rates, this is with about 1 year follow-up on most patients. 20% had no evidence of disease, so these were the stage 2 and 3 patients that had surgery. 36% had recurred or were stage 4 but still alive. 37% died of disease, 6% died of a cause that we couldn't determine, but most likely from their cancer. When we put all these, when we did the statistics, the 1 year overall survival rate was 46% for all patients that presented. It's unheard of to talk about 1 year survival rates in the US for colorectal cancer. I also do pancreas surgery. Pancreatic adenocarcinoma is one of the more aggressive cancers. We still don't talk about 1 year overall survival rates. So this shows the dramatic outcomes for patients that come in with such late stage disease in a place where resources are really limited. When we split out the data between the patients below 50 and over 50, The only real difference was in rectal bleeding, where that was more common in the older patients. Otherwise, the location of the tumors in the right side, in the rectum, the stage of presentation, survival data, everything seemed to be pretty similar between the two groups. But this has led us to ask some additional questions. So we're working on a lot of training, and I'm going to get into a minute into a bit of an early diagnostic study that we're doing. But we're also asking some questions about biology, and is there some difference? And some of this, we're taking advantage of what's been already done in breast cancer, because there's been a lot of breast cancer work done, especially in West Africa, looking at why do the women there present so young with what's called triple negative, so they don't have estrogen and progesterone or HER2 receptors. That's considered more aggressive disease, and they have a higher percentage of it there. And so there's been some very good translational work looking into this, comparing West African women, African American women, and Caucasian women to try and tease out why is this. So we're starting to do a similar thing with colorectal cancer, and we have a lot of questions, and we hope we may learn something about colorectal cancer that's applicable here in the US, that may be applicable to our immigrant population, or even just to our general population as we learn more about the disease. So this is just on 33 patients, so no statistics on this. This is our first glimpse at microsatellite instability testing of patients. We have 33 patients that we've tested. You can see the age was fairly similar. This percentage, to have 10 out of 33 microsatellite high, is double or triple what we see in the US. So although it's a very small population, it's a signal that there may be something there. In addition, the microsatellite high patients, in general in the US, those are almost all patients with right-sided colon tumors. And in Nigeria, it was split 60-40, so 40% were on the left side. So this is an odd pattern to see, where we have another 60 specimens that we're about to run this on, so hopefully in the next few months we'll be up to about 100, and then we'll actually be able to make some early conclusions about this. These same 33 patients, we've been looking at some of the common mutations found in colorectal cancer. The blue is Nigeria and the red is Sloan Kettering patients, and you can see that there's some obvious differences in common genes like APC, NRAS over here, and I didn't want to get too far into these data. It's only 33 patients. We also have compared it to African American patients at MSKCC, and there's additional differences that pop up in KRAS, for instance, that's much more common in African Americans compared to Nigerian Americans. And we're not looking at this just out of pure academic curiosity, because in a place like Nigeria, that would be an absolute waste of time. We're hoping to try and learn, is there a way that any of this can factor into either treatment or screening tests that we and some others are talking about. So we have this extra 60 patients. When we get to 100, hopefully that will help us identify which directions we should go into. The data are striking with how poor patients do there. So an obvious question is, how can we diagnose patients earlier? It's unrealistic to think there will ever be a meaningful screening program for the asymptomatic population in most low-income countries. In the next 10, 20, 30, however many years you want to think, it's unrealistic. So we've been trying to think is, how can we narrow down the general population to a very high-risk population where it may make sense to do some screening, or use symptoms as a screen, and then when you screen positive, then we do a surveillance test. So we started by age 45 or over with rectal bleeding. That was your screen. If you fit those two characteristics, then we did a colonoscopy. And we started with 100 patients. The average age was 58. Remember, you had to be 45 or over to even get into this. The duration of rectal bleeding was 6 months. Almost everyone had seen a doctor at some point because of their rectal bleeding. And the diagnoses that they've been told, for the most parts, were hemorrhoids, infections, things like that. And we looked at the symptoms that these patients had. And there were some very common symptoms. Change in stool caliber, what they describe as pellet-like stool. Weight loss was common. Majority of patients also had hemorrhoids. We found 20% with polyps. And this is what we were so surprised at. 20% of the patients had colorectal cancer, which is a huge, huge number. There's no way that 20% of everyone over 45 in Nigeria with rectal bleeding has colorectal cancer. There's a selection about who's making it into us, but that was a very big number. And the second question we asked was, what stage are they? Because if everyone's stage 4, then this strategy is not useful. But the majority of patients were stage 2 and stage 3. That's why in the prospective data I just showed you, there are some stage 2 patients now showing up. It's because of this study. So we looked at the patients with cancer and without cancer, and we looked at duration of rectal bleeding. That was all the same. But when we looked at the change in stool caliber, there was a difference with higher degree of changes in patients with cancer. When we looked at weight loss, much more common in patients with cancer. And hemorrhoids, you can see, is a real problem here because hemorrhoids are common even in the patients with cancer. So like in the US, like anywhere else, if you have rectal bleeding and hemorrhoids, that doesn't mean that that's the only cause of the rectal bleeding. So we took these factors and we made a very simple risk score using age over 45, rectal bleeding, weight loss, and pellet-like stool. And from that, we've created a bit of a model to try and predict what's the likelihood of someone having colorectal cancer. And we've taken that now and expanded it from Isaac City to 2 other cities. And we'll have 300 patients that will be enrolled in this. We're about 250 patients into the 300 patients. And I know from peeking at the data that it's the same, it's 20%. So 20% of these patients have cancer and the stages seem to be the same. So we hope pretty soon this summer we'll have 300 patients and we have this model we created and then we tried to validate it in this 3-city study, and we hope then to be able to show this as a way to potentially try and identify some earlier stage patients. Another aspect of this is the lack of knowledge regarding rectal bleeding, because we looked at these patients and asked them, what did you think was happening? Who did you talk to? Most patients thought that hemorrhoids could cause this. Increased sugar intake was a very common thought. Cancer, we were a bit surprised, although everyone now knows that there are some guys talking about colorectal cancer in these areas, so that may have contributed to this. And 37% thought this could be hereditary. One of the problems in the location we are is in the Yoruba language, there's one word that describes everything that could ever have to do with the rectum and the anus. Benign, pathologic, cancer, bleeding, infection. So everyone uses one word to describe all these problems. So people just say they have this jetty, they have jetty, but it could be anything. So there isn't even a word that describes, rectal bleeding specifically, and that this could be cancer. So that's been a challenge. The challenges are massive. We've tried to stay fairly focused on our question, because if you think too big, then we just spin our wheels. This is a patient who's on the wards right now recovering from a colon resection, and he has a colostomy. And there's small problems, like there's no colostomy bags. So they use plastic bags and tape and are pretty ingenious on how to make use of this. Because of how big a problem it is to have a colostomy, it is culturally a big problem when you tell a patient that you need to have an abdominal perineal resection and you're going to have a colostomy for the rest of your life. There's a large number of patients who are told that, leave the hospital, and never come back. They'd rather die of cancer than have a stoma. So there are issues like this that are cultural that I deal with very little. This is where Isaac and the whole Nigerian team obviously has a much bigger role to play than me. But a lot of this has to do with education and infrastructure and building. So in conclusion, patients with colorectal cancer in Nigeria, and I think it's safe to say we can extrapolate, at least in sub-Saharan Africa, that this is a common picture. And screening is really absent. The screening guidelines that they would look to, which would be our guidelines, are completely irrelevant. And the technology that we use is also unrealistic to think that it will ever be used there. The NIH has recognized this, and there's the second round of grants that we have one actually that is being reviewed as we speak. They've encouraged US-based academic centers to partner with industry to try and translate technology here for diagnostic cancer tests into low and middle income country settings. Because there's some novel ones with cervical cancer using an iPhone, for instance. It can map the cervix, and you don't have to have any knowledge of the cervix or cervical cancer. It'll map it, it'll draw a picture on the iPhone and say, insert a cryoablation probe here. Breast cancer, similarly, they have ultrasound probes now that will, you don't have to know how to interpret ultrasound. You put the ultrasound probe on and it will say high risk, low risk, biopsy, yes, no. You can't see into the colon, you can't see into the rectum without some sort of technology. So we're working on urine tests, there's people working on blood tests, there's people working on alternatives to colonoscopy that are much cheaper. None of these are ready for prime time. I think This is a massive problem for 2/3 of the world that we have no answer for at all, and it's going to take a lot of creativity. So thank you for your time.